So our fifth session for today is on patient care and safety, access, maintaining the line, monitoring the patients in pre, intra, and post dialysis. And to talk about this important and rather difficult to practically implementing this topic, we have with us Mrs. Reena Rachel George. She is the professor and nurse manager at CMC Vellore. She is a prominent mentor and leader among the nursing professionals and has several research activities to her credit. Welcome, ma'am. Hands over to you. Yeah.
Thank you. Hope the slides are visible.
Yes, ma'am. Please put it in a presentation mode.
Yes.
Yes.
So the topic given to me is patient care and safety standards in hemodialysis centers, and in specific regarding vascular access management and patient monitoring. So I would like to base my talk on the recommendations given by CAHO, that is Kidney Disease Outcome Quality Initiative, given by National Kidney Foundation. And they have given recommendations on vascular access management. And this was updated in 2019. So coming to vascular access management, like most of our effort in caring for vascular access is mainly to prevent infection, catheter-related infections, and to reduce the incidences of catheter dysfunctions. So one thing which may be lacking in most of the units is to have an ESKD life plan for each patient. When a patient with CKD has a GFR below 15 to 20 ml per minute, that time itself, we have to have a individualized ESKD life plan prepared for each patient as to like what would be the renal replacement therapy option for that patient. And if it is hemodialysis, what would be the vascular access, whether will it be a temporary one or a permanent one, and permanent if it would be a catheter, AV fistula, like how are we planning to progress from a distal fistula to a proximal one. So an entire ESKD life plan should be prepared, and we should have a regular monitoring system updating the vascular access, the functionality of it, complication risks, potential future dialysis access options. So this should be a regular thing for all our patients on hemodialysis, even before starting the hemodialysis. So first of all, we should have a standard definition for catheter-related infection, which is again properly, specifically given by CAHO. I'm not going into it. They clearly define what is an exit site infection, what is tunnel infection, and what is a catheter-related bloodstream infection, so that we capturing these incidences will be accurate when we follow a standard definition. And it is preferred that we have a team, an infection surveillance team, to track infections, to help prevent and to track infections so that we can intervene in a timely manner. So it is preferred that we have a nephrologist, a vascular access nurse specialist, an HICC person, and a microbiologist or a microbiologist in the team. So first I would like to take you through central venous catheter care protocols or standards. So general principle is that upper extremity is to be considered before the lower extremity if the choices are equivalent. And if AV access is likely to be ready for use in future, then we can have a CVC, that is central venous catheter, placed temporarily till an AV fistula is functional. Even then, a tunneled cuffed central venous catheter is preferred to a non-cuffed, non-tunneled catheter. So now most of the centers are moving to using permanent catheters, that is cuffed tunneled catheters, rather than using non-cuffed, non-tunneled catheters. And if transplant is anticipated in future, again, we prefer tunneled cuffed catheter placed in the right internal jugular vein to preserve the other veins. So, and a non-tunneled internal jugular CVC is considered only for temporary purpose if you are planning to keep catheter in place just for a limited time period, probably 2 weeks, maximum 4 weeks. So timing for CVC removal, a non-cuffed, non-tunneled catheter is temporary, and earlier the guideline used to say 21 days, but now the KDOQI guideline says 2 weeks of inserting the catheter, which becomes a hard target to keep in our Indian setting. And for a cuffed tunneled catheter, there is no time limit given, no maximum time limit. So it is like we have to regularly evaluate the line, the exit site, and any symptoms of catheter-related infection. And if there is any symptom of infection, then we can remove it. There is no time limit given. Now, to prevent catheter-related infection, these are some of the practices that I believe will be followed across the centers uniformly. We follow strict hand hygiene practices and aseptic techniques while handling catheter. Like we encourage or recommend the use of sterile gloves and mask while handling catheter site, and minimum touch technique. As much as possible, don't avoid touching the catheter. And antimicrobial ointment use at the exit site is found to be, like, the evidence shows that there is a difference in catheter-related infection with and without the use of antimicrobial ointment. So this is recommended. And there is no strong evidence showing any difference in catheter-related infection incidences between the types of dressing. So there is no strong evidence to suggest that transparent dressings are better. But most of the centers, they use transparent dressings. So we use Tegaderm here. And prophylactic antibiotic lock, the use of an antibiotic lock to prevent infection, there is no strong evidence. And do not expose the catheter lumen to air, and do not wet the catheter site, especially soon after the catheter insertion, at least 2 weeks after the catheter insertion. Strictly it has to be followed. And an antimicrobial barrier cap to prevent, to prevent or reduce CRBSI in high risk facility, that is recommended. Now it's very important to have regular monitoring, and preferably it will be nice if the same person monitors the access site at least monthly once, so that there is like continuity to see whether there is, like, we have to see the exit site, tunnel, and the surrounding areas of each catheter for signs and symptoms of infection or even dysfunction. So catheter dressing is recommended at every dialysis session. And assessment of CVC also is recommended during every HD session. So the flow sheet should have a checklist, ideally to show that you have checked the catheter site for any symptoms of infection and also for the patency. So that will provide a kind of guideline for the people who are using, because one thing about dialysis, each time the person comes to the unit, it is a different person giving care, different person assessing the CVC site. So it's very important to have proper documentation of the check that the therapist or the nurse has done after assessing the site. So again, for prevention of catheter dysfunction, use of a catheter lumen lock is preferred. So the recommendation is 4 to 5% citrate, but we have difficulty having citrate available. Citrate availability is a challenge, and many of the centers use heparin as lumen lock. But this is very important after flushing the catheter after each dialysis session. It's important to lock the lumen with concentrated heparin or citrate according to the lumen volume. And TPA, use of TPA, that is tissue plasminogen activator 1 milligram per ml as a prophylactic therapy to prevent catheter dysfunction. It is this does not have a strong evidence. So we in our center, we do not use TPA as a prophylactic mode. So when there is a catheter dysfunction, KDOCI recommends conservative maneuvers at the bedside, like seeing the location, seeing the catheter position. But again, we should be careful not to push the catheter inside without cleaning, because that itself can be a source of infection. Then we seek more of pharmacological interventions like interluminal administration of a thrombolytic agent. Like we use urokinase or TPA when there is a clot, and to prevent any clots within the lumen, we use heparin or citrate. So each institution will have its own policy on the concentration that you use for lumen locks. So again, catheter hub cleaning also is important during the connect and disconnect procedure during dialysis at the start and at the end. It's very important to clean the hub and the catheter around with chlorhexidine based solution. So only if chlorhexidine is contraindicated in some patients with sensitivity, allergy, we can use povidone iodine. Again, coming to the preference of location of central venous catheter, following is the order of preference given by KDOCI, and what we follow, the first preference is internal jugular vein, followed by external jugular vein, femoral, subclavian, and lumbar. So if there is no AVF possible because of some reason, then an AVG is preferred to CVC. So coming to arteriovenous fistula or arteriovenous graft, arteriovenous fistula is preferred, and between CVC and AVG, AVG is preferred over CVC due to lower infection rates. But we know the complexity of surgery. People prefer using a perm cath rather than AVG, but I'm just saying the suggestions given by KDOCI. AVF is the best vascular option, followed by AVG, and then followed by CVC. And again, the choice of AV access, whether AVF or AVG, should be based on clinical discretion by the doctors, depending on the availability of the blood vessels and other conditions which can affect the veins. Like it will be usually based on the vascular mapping. And if sufficient time and patient circumstances are favorable for a mature AVF, like if you can wait till an AVF, then it is better to straight away go for an AVF than temporarily have a catheter and then go to AVF. So the suggestion is that in stage 4 of CKD itself, we make a renal replacement therapy option. And if the patient opt for hemodialysis, a vascular access should be created in stage 4 before the patient even require hemodialysis, so that patient will not need an emergent or emergency access that has to be created when he comes in stage 5. And there are also studies showing that just the creation of an AV fistula in stage 4 can decline the progress of CKD into stage 5, which is a really good thing. So having an AV fistula created in stage 4 itself is recommended. So using tunneled CVCs for short-term or long-term duration. So short-term, we can use tunneled CVCs when AVF or AVG is created, but we are waiting for maturation, and a patient has had transplant but had a rejection and requires dialysis, and a PD patient has acute complications which will require hemodialysis, or a patient has a living donor transplant confirmed but is waiting, and we are expecting that the transplant would happen within 90 days. Or it can be that the patient already has a fistula or a graft but has developed some complication, major infiltration injury, where we cannot use the access. We can go for a permanent catheter, that is tunneled cuffed catheter. So for long term, we use it only based on patient preference. Like some patients does not want AV fistula having to get cannulated each time. So they prefer having a perm cath to having a fistula based on their quality of life goals. Then when you know that patient is not going to live longer, so might as well just have the catheter. And absence of an AV access creation option. Okay, because of some reason, we are not able to get proper veins for, or vessels, vein and artery for AV access creation. So only in such circumstances, we go for long-term catheter use. So this is what I was mentioning earlier, that a predetermined dialysis access must be ready to initiate the planned dialysis, should be mature and ready by the time the patient requires dialysis. And in case a patient is started on dialysis with a central venous catheter, we should plan to create an AV fistula as early as possible, within 30 days after the start of dialysis on CVC. So this largely can be a role of the dialysis nurses, dialysis therapists. In our center, we have a vascular access nurse specialist who routinely monitors, assesses patients every month, and also make sure that patients who are started on CVC are seen by urologist or vascular surgeon, and we speed up the process of AVF creation. Again, coming to the location of AVF, a distal vessel, the distal vessels are preferred to be used first, so that like patients will have more vessel options later when there are vascular AV fistula failures, especially when we have more number of years predicted for the patient. It's always good to start with distal vessels and preserve the proximal vessels for later, and non-dominant extremity is preferred to dominant extremity. And again, preservation of vessels is very important for future use. So even when a patient is on fistula, it's very important to assess or check the vascular access and surrounding area prior to every cannulation. That has to be done by the dialysis therapist or nurse, and we should have a checklist on the flow sheet, dialysis flow sheet itself. And any change, skin breakdown or blood flow, access blood flow problem, it has to be documented for further reference and for further management. And we encourage rope ladder cannulation preferred to like using the same site for cannulation. So this reduces the risk for like pseudoaneurysms and skin breakdown. So rope ladder cannulation should be encouraged. And we do not encourage buttonhole cannulation, that is using the same site for cannulation again and again, because there is more chance of infection. But patients who self-cannulate can be taught buttonhole cannulation. And we have to protect central and peripheral arteries as much as possible, avoiding unnecessary venipunctures or unnecessary pressure on the limb. So again, as I said, it's always advisable to have the same person to, I know each dialysis session, we cannot have the same person assessing. It will be the concerned assigned dialysis nurse or therapist, but on a regular basis, monthly once, the patient's vessel or AV access should be examined, assessed, and documented by a vascular access nurse specialist or a dialysis registrar, or like whoever in your team is competent to do that. That will allow kind of continuity of care. We can identify any complications early and we can save the fistula. And ultrasonography can be done to see the access blood flow rate as well. That, according to the institutional policy, can be done once a month or once in 3 months. So here, our vascular access nurse specialist does access blood flow check for all the patients monthly. So when a patient is posted for fistula or graft, this I'm not going into detail because it will not be like it will be taken care by the urology or the vascular surgery team. So we have to, but after creation of fistula, we have to evaluate for AVF maturation. So that has to be done by an expert, like by the dialysis registrar or by the senior dialysis therapist. We have to ensure whether the fistula is ready for cannulation. And this also has to be documented carefully. And if there is any infiltration, CAHO has given guidelines how to manage infiltration. For mild infiltration, it is applying ice for a minimum of 10 minutes and reducing the blood pump speed. And if it's a moderate infiltration, the needle should be removed and manual pressure should be applied along with applying ice. And if the infiltration is large, then we may have to remove the needle, and we might not reattempt in the same area. And we can use ultrasound to determine the direction of flow and proper needle placement. We should not injure the access by trying to recannulate the injured area again and again. So it is better to give rest to the area when there is a large infiltration, even if it means that like we have to assess whether the patient requires dialysis that same day, or like we can give, according to our clinical judgment, we can give rest. Again, AV access flow dysfunction, it is can be due to underlying stenosis or thrombosis, and it has to be monitored. So CAHO does not recommend a standard guideline to intervene thrombosis or stenosis. It is based on the clinical judgment that we determine the mode of intervention. So this is something that is recommended, to have routine AVF surveillance by measuring access blood flow, pressure monitoring, imaging for stenosis, additional. This is like they say, sorry, there is inadequate evidence to recommend routine AVF surveillance by doing extensive things like pressure monitoring and imaging for stenosis, unless patient has any problem with the flow. But general surveillance is recommended. So this is basically to be determined by the nephrology and surgical team, how to intervene in case of stenosis, whether to go for balloon angioplasty or whether to go for surgical correction, use of stent. So surgical correction is recommended only when there is failure of endovascular treatment. So coming to another complication of AV access, AV fistula or graft infection, we have to educate patient the importance of simple things like washing the access arm with an antiseptic lotion or soap before coming for dialysis, before every cannulation, and to check the vascular access and surrounding area for any symptoms of infection. And radiological image, this is done only to confirm if you suspect infection. To confirm the infection, we can have radiological imaging. So if we suspect infection, then we have to get culture and sensitivity of the blood or any infected AV access vessel. And we have to start the patient immediately on broad spectrum antibiotics.
Excuse me, ma'am.
Yes.
It's overshooting time.
Yes, yes, I'm finishing.
Yeah, thanks.
So it is important to have good cannulation techniques, angle of cannulation, rope ladder technique, securing cannula, and maintaining the distance from anastomosis 2.5 centimeter and between needles. And it is very, very important to have structured training and supervision for the nurses and dialysis therapists to maintain cannulation competency. This is something that has to be done in the centers where structured competency training should be there. And we can train especially some people for difficult cannulations. Again, Steele syndrome, I'm not. Okay, monitoring patients before dialysis, we usually see the pre-dialysis weight, calculate the ultrafiltration based on the weight gain, the oral fluid intake that the patient is planning to take, and any antibiotics or blood products that we are planning to give. And then before dialysis, we check the blood pressure and oxygen saturation, temperature, and the vascular access site has to be assessed. So during dialysis, every 30 to 40 minutes, patients are to be monitored. The parameters that we monitor are blood pressure, blood flow rate, venous pressure, arterial pressure, transmembranous pressure, ultrafiltration rate, heparin flow, and any infusion, normal saline infusion if you are giving. And also access site is assessed to see whether there is any dislodgement and signs and symptoms of complications. And after dialysis, again, checking blood pressure after retransfusion before disconnecting the needles so that we can give any fluids if necessary before the patient goes out. And we have to again check the blood pressure after the needles are removed, after the cannulas are removed. And then we have to check the weight and net ultrafiltration pressure. It's recommended that we check a standing BP also before the patient leaves the unit. So again, teamwork is the most important thing. Together, everyone achieves more. So we should have standards, protocols, and procedures laid out in each unit, and competency training of the staff is very important. Periodic audits that has to be conducted to see the vascular access management and the assessment that is whether according to the protocol it's done. And good documentation system is very, very important, and identifying performance indicators for each of this and having performance measures in place and a coordinated teamwork is the key to success. So thank you. Sorry for overshooting the time.
Thank you, ma'am. It was a comprehensive talk. There is a famous saying that prevention is better than cure, synonymous to the same. Thank you, madam, for guiding us to safe practices and eliminate errors in the dialysis room.